less often addressed topic, that's acute limb ischemia. What are the current management strategies in this? So what's the definition? It's a sudden loss of decrease in the limb perfusion and potential cost to the limb viability. So historically the amputation rate is almost 10 to 25%, and also the mortality rate is also very high because the diagnostic error can lead to a loss of limb as well as life. And in this topic I am going to discuss about only the lower limb ischemia, and upper limb ischemia I am not going to address. The main causes of lower limb ischemia is going to be a in situ thrombus contributes about 40%, and embolism it's about 38%, and a bypass post intervention graft thrombosis can happen, and sometimes thrombus from a popliteal artery aneurysm or a thrombus from an aneurysm of the abdominal aorta can dislodge and cause acute limb ischemia. So trauma and iatrogenic causes contributes about 2%. And newer causes like a post-intervention acute limb ischemia can happen, and also vascular closure device can occasionally cause acute limb ischemia. So most commonly we encounter cardiac source of embolism, either from the atrial, left atrium or left ventricle, from the left atrial appendage, or neural thrombus from following myocardial infarction, or even a left ventricular aneurysm can throw a thrombus. So rarely a processing valve can cause a thrombus and distal embolization. Sometimes we may encounter paradoxical embolism, like a patient with acute DVT, if they are having associated septal defects, can like a patent foramen ovale or a ventricular defect, they can go through an embolus to the arterial system. And endocarditis and cardiac tumors are fewer causes. And non-cardiac sources like sources from the proximal arterial tree can cause, and it is, can cause a distal embolization, like a ruptured block in the aorta or in the iliacs can cause a embolism to the distal arterial tree. Rarely an aneurysm that I have already mentioned, and gap, fat and amniotic fluid can also cause acute limb ischemia. So thrombosis, already a diseased vessel, can go for acute thrombosis, and sometimes a hypercoagulable conditions like thrombocytosis or malignancy can cause acute limb ischemia. So the clinical presentation is largely depends on the type of collaterals they develop, because in acute limb ischemia the patient is already having a compromised vascularity with a stenosed vessel. The acute limb ischemia will be less severe, rather than if the vessels are virgin vessels, the limb ischemia will be more severe. And in acute limb ischemia, the sensory nerves are affected first. The loss of sensation is the first sign, followed by motor sensation loss. And motor nerves are affected next, followed by skin, and finally the muscles and bones are affected. So this is a classical P of acute limb ischemia: pain, pallor, pulselessness, paresthesia, and paralysis and perising cold. That's the classical teaching. So this is a classification which we largely follow. The class 1 is the limb is viable, not immediately threatened. This is a Rutherford classification, still it holds good. And sensory loss will not be there, muscle weakness will not be there, the arterial pulse will not be palpable, but you will be able to pick up the arterial signals through the handheld Doppler. So venous signals will be also there. In 2A, the limb is marginally threatened and salvageable if promptly treated. So the sensory loss will be minimal, confined to the toes, and muscle weakness will not be there. And the arterial signals will not be audible, and venous signals will be audible. And 2B, the limb is immediately threatened. Here, urgent revascularization is needed, and salvageable with immediate revascularization, and the sensory loss will be more profound, and the muscle weakness will be there. Here also the arterial signals will not be there, and venous signals is audible. In class 3B, the limb is already damaged, and then it will be paralytic, and the permanent nerve damage will be there. So the arterial and venous signals will not be heard. So it's a class 1 ischemia. You can notice some duskiness, but movements and sensation is preserved. So class 2 ischemia. Here you can notice the cyanosis of the toes. So typical class 3 ischemia. Here you can see the mottling as well as paralytic limb here. So the tissue threshold for ischemia, the muscle can withstand ischemia up to 4 to 6, 8 hours, and now 4 to 8 hours, and fat 12 hours, and for skin it is 24 hours. So whenever the skin changes occurred, it's a loss site. So the underlying muscle, nerve, everything has gone. So after when the skin is discolored, it is not worthwhile to attempt a revascularization. So therefore a viable or functional limb if the upper threshold is about 6 hours. But unfortunately our patients will come only after 6 to 12 hours because there will be some diagnostic delays. So investigation we can go about with a handheld Doppler. The signals may be reduced or absent. Color Doppler can be done. But most often if the patient comes with the acute limb ischemia, you have to go for a angiogram rather than a color Doppler. And these are the types of angiogram available. You can go for CT angiogram or a transfemoral angiogram, MR angiogram. Routine investigations like CBC, RFT, FPT-INR and ABG has to be taken because most patients will present with an acidosis too. And echo is mandatory to rule out valvular heart disease as well as to rule out the cardiac source of embolus. And you have to look for the ejection fraction as well as the regional valve motion abnormality. And CT angiogram is very widely available now, and it is non-invasive, and it can accurately pinpoint the location and extent of the occlusion and condition of the vessel, and also the distal tree you can see. And diagnostic angiogram is a gold standard. It is now replaced by CT and MR angio. Whenever possible, you can subject them for diagnostic angiogram because we can also accurately detect the lesion, also treat the therapeutic intervention can be done simultaneously. So this disadvantage, it is expensive, and also it is not previously it is not widely available, and it is also invasive as well as expensive. So MR angiogram, whenever the urea creatinine is high, you can go for MR angiogram or carbon dioxide angiogram. So aortic occlusion, when a thrombus lodges in the aortic bifurcation, we call it as saddle thrombus, and the images which shows thrombus in the aortic bifurcation, the both lower limbs will be paralyzed. And this is an example of iliac occlusion. So coming on to the management option, you have got endovascular as well as open as well as hybrid options, like open as well as endovascular options are available. So for Rutherford class 1, type 1 and 2A, historical trials like Rochester trial and Topos trials are there. More than 1,000 patients are included in this trial. They compared the efficacy of the surgery along with the catheter-directed thrombolysis. Catheter-directed thrombolysis like using agents like alteplase, tenactipase and all. So the clinical outcomes are similar, and the patients with symptoms of longer duration are better benefited with surgery. So this is a historical trial. So it is applied only for Rutherford type 1 and type 2A lesions. And now newer gadgets are available. if the patient is having contraindication for thrombolysis, you can go for thromboaspiration with the dedicated catheters like export catheters are available, and ultrasound accelerated thrombolysis is also available. And sometimes the patient is having needs an urgent revascularization, like in a type 2B where the duration is very less. In the catheter directed thrombolysis, we need to give the lighting for almost 12 to 24 hours. The the acting time will be more. In order to cut short the time and also reduce the loss of thrombolysis, we can go for a pharmacomechanical percutaneous mechanical thrombectomy can be combined with thrombolysis using the newer gadgets like Rotarex and Angiojet that will come up. Yeah. So this newer it's a usage of an angiojet device. Here, this catheter is having dedicated catheter is introduced in the arterial system and used to inject some volume of thrombolysis along with the so this works by a Venturi effect, that it lyses the thrombus by mechanical means and lyses the thrombus, and also the after 20 minutes we can again aspirate this thrombus like this. So it acts very fastly. And another system is a Kelly system where we have got two balloons which isolates the thrombus and a wire here which rotates and lyses the thrombus, and you will be able to support the thrombus later on. It's another one device is a penumbra device which works by aspiration alone. So you can see the occluded segment of the femoral artery, distal femoral artery here, and after using a penumbra you can able to see the successful revascularization. So the newer system cuts short the time. So there are multiple trials available regarding this use. The Payout registry, peripheral use of angiojet rheolytic thrombolytic with varieties of catheter and lens. So all these have shown the patients treated with angiojet have a lower lytic dose and shorter procedure and fewer treatment sessions. So previously we used to go for CDT alone. Now with these available gadgets, we will be able to do this thrombectomy as at the earliest and also with shorter duration. So post procedurally, sometimes this patient may need a re-intervention like addressing a stenosis, underlying stenosis, and also they are prone for compartment syndrome. So if they, after the endovascular procedure, if they are going for, you have to watch closely for the compartment syndrome, and sometimes fasciotomy may be needed. And even after a successful revascularization, the amputation rates may be after 5 years it is about 9%, and 1 year mortality surprisingly it is high because all these patients will be having multiple comorbids. So the mortality rate is always high with acute limb ischemia. So one this is a slide trial which incorporates penumbra. So the limb salvage is almost 98%, and the major bleed is reduced compared to the previous roster and topos trial. So sometimes we may need an angioplasty of stenting to treat an underlying lesion. So the newer guidelines, ESBS 2020 acute limb ischemia guidelines shows that endovascular and surgical approaches have similar rates of short-term and 12 months mortality, limb amputation and recurrent ischemia. So PMT is indicated in Rutherford stage 2B. Previously, endovascular option is available only for stage 1 and 2A. Now with the available newer gadgets, we can extend this for 2B patients also. So this newer ACC AHA guidelines shows that the mechanical percutaneous thrombectomy is equivalent in hospital lymph and mortality outcome compared to open thrombectomy. So the endovascular thing is picking up now compared to the open surgery. So open surgeries has still some role because it is economical, and if sometimes the endovascular approach fails, you can always go for open surgery. So one case we did recently, a case of acute limb ischemia, where you can see the thrombus extending from the common femoral up to the popliteal, and this extension with the profunda femoris artery. So we will be able to do this in probably half an hour or 40 minutes time. So it is very quick and fast, and also we can give a lasting results with the open surgery, and the cost factor is also very less compared to the newer gadgets. So sometimes even open surgery or endovascular fails, you can offer a hybrid treatment, like even after incomplete thromboembolectomy, you can go for an intra-arterial thrombolysis or thrombus aspiration with the endovascular gadgets, or sometimes even after an endovascular procedure fails, you can go for an open and open thrombectomy, or sometimes even open bypass may be needed to salvage the limb. So these are some. So most often after doing an angioplasty or an intervention, we used to close the access site like common femoral with the vascular closure device like your angio-C or prograde. So sometimes it can cause acute limb ischemia when it is not properly deployed, or there is a technical failure. So angio-C or short force to achieve rapid hemostasis, but it can cause intraluminal thrombosis, or sometimes it can embolize distally. Few examples I have come across that proglide which has migrated and caused acute limb ischemia, and sometimes repeated puncture can cause acute limb ischemia like this, and we are able to come away with a short bypass from common femoral to superficial femoral. So one case of acute limb ischemia, we are able to salvage with thrombolysis and again thrombus aspiration. So you can see the acute cutoff of common femoral. So this is a management algorithm. If it is class stage 1, conservative management, you can go. Stage 2A, urgent imaging and selection of endovascular technique like CDT or percutaneous mechanical thrombectomy can be done, or you can go for an open surgical technique. So class stage 3, it is irreversible. You have to go for amputation only. So always after endovascular or open surgery, it is better to have a completion imaging, and also you have to address the underlying lesion like a stenosis or by either hybrid, by either endovascular or by a hybrid approach. Thank you. Thank you for your time.